Well, hello there, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and the founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. We also often address common concerns and dilemmas that come up with aging parents and other older loved ones, like what to do if you're worried about falls or safety or memory, or even the quality of an older person's healthcare. In this episode, I'm going to talk about something that I'm often asked about, which is common causes and types of dementia. Now, you probably have already heard of Alzheimer's disease. It is, in fact, the most common cause of dementia. But there are many other conditions that can cause dementia, and these are sometimes referred to as different types of dementia. So, if you've been dealing with a diagnosis of dementia, or have heard about Alzheimer's, or have been concerned about memory or thinking problems in an older adult, it's possible that you've been wondering what type of dementia you might be dealing with. Or maybe someone has told you that it might not be Alzheimer's and that it's important to find out what type of dementia it is. Now, I actually have mixed feelings about how important it is to identify the specific type of dementia, especially in people over age 80. And in this video, I'll be telling you a little bit more about why and what is my approach to types of dementia. But if you are dealing with dementia or even a diagnosis of Alzheimer's, I think it's a really good idea to learn more about this condition and to familiarize yourself with the most common types of dementia. So, in this video specifically, I'll be covering the main types of dementia that we see in older adults, especially when it comes to people over the age of 80. And then I'm also going to talk about some other types of dementia that you might hear about or read about if you go Googling about dementia online. I'm also going to spend some time talking about mixed dementia. This is actually the most common type of dementia in people that I see and that I work with. And I'm going to talk about when it might be important to find out what type of dementia you are dealing with. And again, I'll share more about my usual approach to using dementia type to help families. But before I go into dementia types, just a few words about what is dementia to make sure that that's clear to you if you're watching this video. So dementia is also known as major neurocognitive disorder, and it's essentially an umbrella term and a clinical syndrome. So that means it kind of defines a collection of symptoms that we see, and it can be due to many underlying causes. So to diagnose dementia, these 5 things have to be true. So first of all, a person has to be having chronic difficulty with a cognitive function. And in the DSM-5, which is the Diagnostic and Statistical Manual, what doctors use for the diagnosis of any conditions that affect the mind or mental health, the DSM-5 defines 6 types of cognitive function that can be affected. And they are memory and learning, language, executive function, complex attention, perceptual motor function, which includes visual spatial processing, and or social cognition. Next, the difficulties have to be a decline from prior abilities, from the way the person was in their adulthood. Third, the difficulties have to be bad enough to impair daily life function. So that means they have to be bad enough that the person is no longer independent in some kind of task or activity that they used to do independently as an adult. And so this could be something like some aspect of their work. It could be planning and cooking a meal. It could be doing their finances, but in that case, the person has to have been able to do their finances previously. So that's a really important criteria to diagnose dementia. And it is one of the criteria that distinguishes dementia from something like mild cognitive impairment, which by definition is not bad enough to affect independence in daily life activities. And if you want to learn more about the difference between MCI, mild cognitive impairment, and dementia, I have a video that goes into that in depth. So also to diagnose dementia, the cognitive problems, so the problems with memory or thinking, can't be due to delirium or some other reversible illness. And delirium is that state of worse than usual mental function that we see happen when people are very sick, especially older people in the hospital. So if you've ever heard, sometimes people even call it, hospital-associated dementia. But if it happened in the hospital or while somebody was ill in the context of being sick, it would probably be delirium. And then lastly, For it to be dementia, the problems with memory or thinking can't be better explained by another mental disorder. So for instance, they can't be better explained by conditions such as schizophrenia, major depression, bipolar disorder, or another significant mental illness. Now, you might be wondering, is dementia common? And we got a really good answer to that question recently in the 2016 Health and Retirement Study survey. So the Health and Retirement Study is an ongoing longitudinal nationally representative study. And in 2016, they added on a special subset called the Cognitive Assessment Protocol Project. And so that means that they assessed lots and lots of people for mild cognitive impairment and for dementia. And what they found as the prevalence was that when people were in their mid to late 60s, 3% of them had dementia. And that kept going up as people got older, especially once people got into their 80s and 90s. So for people 90 plus, it was 35% of them who had dementia. So it does become common, especially as people get in their 80s. And now, what actually causes dementia? So in a moment, I'm going to go through the different types, but, at a bigger level, dementia usually develops over time as brain cells become damaged and malfunction and die due to some kind of condition or problem affecting them. So this is often referred to as a neurodegenerative process because it takes time for the neurons to get sick and degenerate. And again, it's usually caused by one or often more than one underlying diseases or conditions. And those kind of relate to the types of dementia that we are going to talk about. Now, Alzheimer's disease is the most common cause of dementia. So we can say that Alzheimer's disease is a subset of dementia. But there are many other causes, which I'm going to talk about in this episode. And it's important to know that damage to brain cells has almost always started years and years before mild symptoms become apparent. So people really usually need to have a lot of brain cells affected before their memory and thinking is affected. And that's because otherwise the brain tends to recruit from other healthier neurons to do the work that it's trying to do. Now, how are dementia causes identified? So this is kind of interesting because we have sort of like a clinical outside version for dementia diagnosis and identifying the causes and a sort of inside version. So the outside version is the one that most of you will encounter in routine medical care and the one that I'm usually involved in. So in clinical medical care, we start to evaluate somebody because there have been concerns about their memory or thinking, and we're kind of looking at it from the outside of the brain. So to do an evaluation, we ask about symptoms, like is it memory or are there other forms of cognitive change that are worrisome? If you want to know more about sort of signs that might be Alzheimer's or another form of dementia, I have a video about that, 21 signs. We ask about the history. So when did the symptoms start? How have they evolved over time? We also do cognitive testing. In the office, it can be a pretty short office-based cognitive test, or sometimes there's more involved neuropsychological testing. So that's to get an objective kind of evaluation of how well the person's memory and thinking processes are working. And then especially in geriatrics, we do functional assessments. So that means asking questions to find out how well people can do their activities of daily living, and especially their instrumental activities of daily living. So daily life tasks that we learn usually as teenagers and that are important to being independent as an adult, like finances, driving, managing your email and correspondence, managing your grocery shopping, meal preparation, home maintenance. And we also ask just what else is the person having difficulty with, because that's very important. Then we'll usually do lab tests, in part to help rule out medical conditions that are dementia mimics. So for the types of dementia that I'm going to talk about, they usually cannot be identified on a regular lab test. And so the lab testing is really more to rule out other things that might be affecting memory and thinking. If you want to learn more about that, I have a video about 10 common causes of cognitive impairment in older adults, and that goes through the things that doctors are supposed to check to sort of identify common medical conditions that might be contributing. And then there's the role of imaging. So a CT, a CAT scan of the brain, or an MRI. So this is often useful Again, for ruling out other things that might be affecting memory and thinking. So on a scan, we can first of all make sure that the person doesn't have a tumor, that they don't have a big hematoma or blood clot that might be affecting their thinking. So an MRI can be helpful for that purpose. Sometimes it also shows which parts of the brains have shrunk, and it can also show small scars in the tissue. These are called white matter hyperintensities that are often associated with vascular cognitive impairment. What's important to know, though, is that a brain CT or MRI cannot by itself identify dementia causes, and it can't even definitively identify dementia. I have people tell me this, that they got an MRI and the MRI showed they had dementia. Well, to diagnose dementia, we have to establish that there is enough change to memory and thinking processes that independence in activities is impaired. So you can have a terrible looking MRI, but if you are still well enough with your memory and thinking to be independent in your activities, it doesn't meet the criteria for dementia. So that's what I'm often explaining to people. So that's the sort of clinical from the outside evaluation of dementia. And then there's another way to do it, which is from the inside. So if we want to really know what made those neurons get sick, malfunction, die, we really have to look at the neurons themselves. And because we don't routinely biopsy brains, the way this is usually done is through autopsy studies after people have died. Because in an autopsy, we can do what's called a neuropathology evaluation. So pathology basically is the science of what is going wrong with organs, with human bodies, or potentially with human cells or non-human cells. And neuropathology means examining aspects of the nervous system, like the neurons in your brain, or sometimes the nerves outside your brain, and taking a good look to see what is causing them to not work well or what caused them to die. So that is the most definitive way to evaluate dementia causes. Now, it's also possible to come close and make a good guess through specialty clinical care, such as a memory clinic. So these clinics are staffed by healthcare providers who have lots and lots of experience evaluating potential dementia, and they're often able to make a good guess based on symptoms and history. These clinics also usually are able to have a much longer interview with a patient and with the family to learn a lot about what's been going on. They also usually include in-depth neuropsychological testing, and they might do a more detailed MRI of the brain, something called a volumetric MRI that can really drill down into which parts of the brain specifically might be more shrunken than expected. And that often helps the experts hazard a guess about what type of dementia they are working with. And then there are research studies and kind of newer special tests that look for certain proteins associated with certain types of dementia or other signs. So there can be special scans that look for this, like special scans that identify amyloid in the brain. And as I'll explain, amyloid is associated with Alzheimer's disease. Or there can be other biomarkers either in the spinal fluid or sometimes that are being experimentally used in the blood. Given that, let me now talk about what are the most common types of dementia, because there are actually many conditions that can cause dementia. But when it comes to older adults, so most cases of dementia are affecting people who are age 80 and older. And in most cases, they really seem to fall into these 4 types of dementia that I'm going to share with you right now. Based on autopsy studies, the most common causes of dementia are number 1, mixed dementia, number 2, Alzheimer's disease, number 3, cerebral vascular disease, and number 4, Lewy body disease. So let me now take you through a little bit more about each of those types of dementia. We're going to come back to mixed dementia in a bit. Let me start with Alzheimer's disease. So this is the type of dementia that, is best known. It is, based on autopsy studies, seems to be involved in 60 to 80% of dementia cases. And the typical early symptoms are especially short-term memory loss. Now, not all short-term memory loss is Alzheimer's disease or even dementia, but it is pretty typical if somebody is developing Alzheimer's disease that has progressed to the point where they're getting symptoms. And again, by that point, they've usually had the signs of Alzheimer's slowly progressing in their brain for at least 10 years. But typical early symptoms include short-term memory loss, executive dysfunction, reduced insight into one's problems, so kind of unawareness that one is having difficulty with some aspect of memory or thinking. And then other early symptoms might also include problems with visual spatial processing. That's an early sign for some people. Language problems can be an early sign. It's not uncommon for people to start having delusions, false beliefs, maybe falsely accusing other people. They might become quite paranoid. Or another common early symptom is apathy and kind of losing motivation. And so what is the neuropathology of Alzheimer's? So really broadly, it basically involves what they see on autopsies and studies is they see that the brain develops these plaques of amyloid. So amyloid is a protein that is produced by the body, but in Alzheimer's disease, it ends up clumping together and making a lot of it that makes these plaques. And there are also tangles of something that is called tau. And then there is cerebral vascular disease. So this is estimated to contribute to 50% of dementia cases. And cerebral vascular disease, vascular means of the blood vessels and cerebral means of the brain. So this means some kind of problem with the blood vessels that are in the brain. Now, this can happen from a very large blood vessel in the brain being affected. When that happens, that's generally a major stroke, and people can have dementia after a major stroke. But often, what's especially common is for the very small blood vessels of the brain to be affected. And so that tends to cause, first of all, people can have a lot of that being affected and not show symptoms. And then when they show symptoms, they can start off as fairly subtle. So the typical early symptoms for cerebral vascular disease, and this is called initially vascular cognitive impairment. If it gets bad enough, it can be vascular dementia. Typical early symptoms are impaired executive function. So executive function is the front of the brain that kind of does planning, processing, prioritizing, weighing decisions. We can also see slower processing speed, and we can sometimes see short-term memory issues. Other early symptoms might include problems with walking or walking more slowly or being a little bit off balance. Another potential early symptom is depression. There have been some studies that have identified that, especially if it's the person's first time ever getting depression in later life, that seems to sometimes be associated with vascular cognitive impairment. We can also see apathy, loss of motivation, and in some cases, we can also see some delusions or paranoia. And in terms of the neuropathology for cerebral vascular disease, what's very common is to see signs of cerebral small vessel disease. So on an MRI, this shows up as little kind of white spots. They can be called white matter hyperintensities, or small vessel ischemia in the radiology report, or there might be small hemorrhages. Or there can be just another form of damage to the brain's blood vessels. Now, what you should know is that it is extremely common for people to develop white matter hyperintensities. They're basically like little scars in the brain where little blood vessels have had a problem. So most older adults, especially once they get into their 80s, have at least some signs of this on MRI. And so it's only if there's a lot of it or if there are other symptoms that we would consider it very concerning. I mean, it is a sign of suboptimal vascular health, right? It's often associated with having had high blood pressure or maybe diabetes or smoking. All those things that are bad for heart health are also bad for the health of blood vessels in the brain. So if you find out that you or somebody you care about on their MRI had some signs of these white matter hyperintensities, please don't panic. And if you want to learn more about how to think about that kind of MRI finding, I explain that in more depth in an article on Better Health While Aging about cerebral small vessel disease. Now let's talk a little bit about Lewy body disease. So Lewy body disease, which can lead to Lewy body dementia, seems to be involved in probably about 20%, maybe up to 30%, but the newer studies I saw seem to think it was closer to 20% of dementia cases. And what's interesting about Lewy body dementia is that to make a clinical diagnosis of that, this is a form of dementia that actually is associated with a few pretty specific signs that we don't see so often in other forms of dementia. So they're called core clinical features of Lewy body dementia. So diagnosis requires at least 2 of these 4 core features. And the features are 1, visual hallucinations. So stereotypically, it can be small children or animals in the home. sometimes adults. And then there's some people who just see colors or shapes, but visual hallucinations is one of those core features. Another one is REM sleep behavior disorder. So people moving more when they're in dreaming and in REM sleep, because otherwise, normally the way the brain is designed is that when you're dreaming, the rest of your body is actually kind of paralyzed. Then another core feature is to show Parkinsonism. So Parkinsonism is related to Parkinson's disease, but is not entirely the same thing. Parkinsonism refers to a collection of movement or motor symptoms that is very classic in Parkinson's disease, but can also be caused by some other conditions that affect the brain and the nervous system. So the sort of key symptoms of Parkinsonism are slowed movements, resting tremor. So that means when, especially in the arms or hands, when the person just rests it, if it's like moving when they're not doing anything, that would be a resting tremor. Stiffness. So if we try to move their arm kind of back and forth this way, they feel kind of stiff. And then there's balance or gait issues. And then the last core feature is cognitive fluctuations, which basically refers to people having, a significant change in their level of alertness or arousal or cognition. So they might seem at times very zoned out or very confused or seem to be falling asleep. And then other times they might seem almost normal. This can come on fairly quickly, or sometimes it comes on more slowly. It can last just briefly, or it can last for a longer period of time. And it's really supposed to be more than people with dementia often have kind of good days and bad days, good moments, bad moments. They tend to be better early in the day when they have more energy. And as they get tired in the afternoon, they get worse. So the cognitive fluctuations of Lewy body disease are really supposed to feel like more than the kind of good moment, bad moment that we otherwise see in other forms of dementia. And so the neuropathology of Lewy body disease involves Lewy bodies. These are accumulations of something called alpha-synuclein protein, and they start to accumulate in neurons throughout sort of the brain. The cortex is kind of like the main outer part of the brain. Now, Lewy body disease is related to Parkinson's. There's kind of debate about how exactly to connect them, but Parkinson's disease also involves Lewy bodies. But in Parkinson's, it's this part of the brain back here that regulates movements and motor function that is initially affected. And so with Parkinson's, it's really that part that's affected. You have, a lot of the typical Parkinsonism signs, but you don't see as much, you don't see the other, first of all, clinical core features as much of Lewy body, and the significant cognitive problems tend to come much later in Parkinson's disease. So those are, really the main types of dementia that we see among older adults, especially the ones who are 80 and older. Now, there are a few other causes that I might consider in an older person. So there is Parkinson's disease dementia. Now, this one, we kind of see it because it tends to happen after people have had Parkinson's for several years, often about 10 years. So we wouldn't be thinking about Parkinson's disease dementia if the person has developed cognitive problems just over the last few years and gotten worse. This is really for somebody who, had pre-existing Parkinson's. But there are a few other causes. So there's alcohol-related dementia, which is another kind of umbrella term for problems, chronic problems with memory and thinking that are related to years of alcohol abuse. And there's something called Korsakoff syndrome that is associated with this, and there may be some other forms of alcohol-related dementia as well. Usually, if we ask or inquire, either asking the older person or asking family members, knowledgeable people, we might find out that the person has been drinking fairly heavily for quite a while. And then there's chronic subdural hematomas. So a hematoma is a collection of blood, and when people fall and hit their head, they can bleed and develop a big blood clot kind of on the surface of the brain, under the lining of the brain and under the skull. And because the skull is hard, if you get a big enough blood clot, it's pressing down on the brain, and that can cause dementia symptoms. And so every now and then, an older person who has gotten confused or cognitively declined, if we scan them, we find that they actually have a pretty significant collection of blood. And that big collection can stay for weeks, for quite a while. And sometimes it makes them even sicker, and we find it faster. But that is a known phenomenon, chronic subdural hematoma. And so we might consider that as well for an older person who seems to have dementia. And then there's a condition called normal pressure hydrocephalus. So in this condition, so in the very center of the brain inside, there is something that is called the ventricles of the brain. And it's kind of like a space in the middle of the brain that makes the cerebral spinal fluid that ends up going down around the spine and kind of ends up coming out and sort of soaking around the brain. So in normal pressure hydrocephalus, that drainage of that space gets blocked. And so that space in the middle of the brain starts to expand because it has all this fluid building up in it with nowhere to go. And that can cause dementia symptoms. The sort of classic symptoms are a triad of dementia, urinary incontinence, and a change in gait as well. So this condition can be treated and symptoms can improve if doctors place what's called a shunt. So a kind of passageway, sort of a drain in a way that goes from that space in the brain that needs to drain into the belly. The thing about normal pressure hydrocephalus is that, first of all, it's not all that common. So in one study of people who had been referred for neuropsychiatric testing and gotten detailed MRIs in people who were in their 70s, only 0.2% of them were judged to have likely normal pressure hydrocephalus. And in people who were 80 and older, the percentage was higher. It was 5 or 6%, but that's still not most of them. The other thing that has also been noted is that a lot of older adults, especially if they're in their 80s, who have normal pressure hydrocephalus, also, if they are studied in depth, have signs of Alzheimer's disease or another form of dementia. And so that means putting in the shunt may not entirely resolve all these symptoms and problems. So those are the most common causes of dementia in older adults. But if you Google to learn more about dementia, you will probably hear about lots of other causes of dementia that are out there. So let me take you through some of these. These mostly affect people under age 80, and some of them are even, more focused on people younger than that. They include frontotemporal degeneration. So this is a condition where either the front or the sides of the brain start degenerating. There are two main variants, behavioral variant and primary progressive aphasia. So behavioral variant, people start off by, almost developing a personality change and becoming kind of inappropriate, saying inappropriate things. Whereas with primary progressive aphasia, they start off by really having difficulties with language, either with creating language or understanding language. And that is apparently the variant that Bruce Willis was diagnosed with. The thing about frontotemporal degeneration is that experts estimate that, over 60% of cases are in people who are age 40 to 64. So you can have people in their 60s and 70s diagnosed with it as well, but it becomes relatively uncommon as people get older and older. So then there are some other causes of dementia. These are relatively rare. There are 3 conditions: progressive supranuclear palsy, corticobasal degeneration, and multisystem atrophy. These 3 conditions are fairly rare. They are associated with Parkinsonism-like symptoms, but they have some other unusual features that show up either in symptoms or on neurological exam. And they, again, are less common in people over the age of 80. There's a cause of dementia that's called Huntington disease. That's a genetic disorder that often starts to affect people when they're in their 30s or 40s, sometimes later. Then there's chronic traumatic encephalopathy. So this is dementia that occurs kind of as a result of lots of concussions earlier in life. So it's been explored especially as something that has affected some former professional football players. It might also affect combat veterans if they experience a lot of concussions or a lot of blast exposure. And then there's something called Creutzfeldt-Jakob disease, which is a prion disease. It's pretty rare, but you might read about that as well. And then there's HIV-associated dementia, which comes on especially in people who have HIV who weren't able to get good, highly active antiretroviral treatment to keep their HIV under control. And so there again, it's not something that we see a lot in geriatrics. So those are common causes of dementia. And, they can have different neuropathology, but in general, a sad but true fact is that most causes of dementia are actually considered uncurable. The various processes that cause these diseases and that end up causing dementia are things that we don't have ways to reverse or stop. So that means that most of the time when it comes to dementia, regardless of the underlying cause, the treatment is usually supportive and focused on helping the person manage symptoms, whether those are uncomfortable symptoms or just cognitive symptoms that are making their life difficult. We want to help them manage that, and we want to help them optimize their function. So help them be as able as possible to do what they can still do, to participate in meaningful activities to them, and to otherwise try to give them the best quality of life possible. So that's true of most causes of dementia. Now, again, there are a few causes that might be potentially treatable. So in older adults, those might include chronic subdural hematoma. They can either resolve slowly over time, or sometimes they can be drained in a neurosurgery procedure. Alcohol-related dementia. Some people, especially if they stop drinking and get treatment for thiamine deficiency, some people can improve and stabilize, but it's not the case for everyone. Normal pressure hydrocephalus, again, sometimes can be treated with a shunt, and HIV-associated dementia sometimes gets better if the person does start good antiretroviral treatment. So let me now talk about some newer information that we have about types of dementia pathology. There's been some really interesting research done over the last 10, 20 years on the brains of older people with dementia. And what people have realized, scientists, is that there are some newer types of dementia neuropathology that are actually quite common in older adults who die in their 80s and 90s. So you might hear about these, and I want to tell you a little bit about them right now. So one is called limbic predominant age-related TDP-43 encephalopathy. What a mouthful, right? So it's abbreviated LATE for short. It involves abnormal amounts of TDP-43 protein. This is a protein that can also be involved in frontotemporal degeneration. But in LATE, it sort of seems to be a little bit of a different process. And what's interesting is how it's quite common. And on autopsy, it's been found in roughly half of brains of people with clinical dementia. Another form of dementia neuropathology is called hippocampal sclerosis. So the hippocampus is a little part of the brain that is involved in memory and learning. And in hippocampal sclerosis, that part, the neurons kind of get damaged and stop functioning. So it involves a loss of neurons in the hippocampus. And they see it become fairly common as people reach age 90 or over. And then there's a third type that I want to mention, which is cerebral amyloid angiopathy, sometimes abbreviated CAA. So this also seems to be fairly common. So in this condition, the body, for some reason, starts to deposit amyloid protein in the walls of small blood vessels, and that keeps them from working properly and often contributes to microhemorrhages. And what they found is that many people with Alzheimer's disease also have CAA. So researchers are still trying to work out how these conditions often seem to kind of synergize in, unfortunately, a bad way for the brain. So as of now, none of these three conditions, first of all, are routinely diagnosed in regular clinical care. And we don't really have a known treatment or way to stop or reverse these conditions. However, there's, interesting research happening to try to see, can we identify these conditions earlier? Is there a way to change the trajectory of these conditions? Because they do all three seem to affect the cognitive health and well-being of older adults. So as I mentioned, we've really learned so much from these autopsy studies of people with dementia or of older adults. And so now I want to share, more of what has been learned. There have been some really wonderful long-term studies that were done of older adults who, some of them were in religious orders, monks or nuns. Others were just people who participated in a memory and aging project. And as part of these studies, participants agreed to come in regularly for cognitive testing, to have their health history really closely followed. And then because they were followed closely, the researchers noticed if they developed dementia. And then when they died, their brains were examined during autopsy. What we learned from an autopsy analysis of 2,695 decedents, they were aged 80 plus, was that 91% of them had more than one of 6 key neuropathologies, and 41% had 3 or more. So this is part of how we know that it's mixed dementia that is really, really common as people get older. And the most common mix that is seen is Alzheimer's pathology, with cerebral vascular disease. But we also sometimes see people who have Alzheimer's, vascular disease, and also Lewy body, or we see kind of other permutations. And in fact, in ROSMAP, so that's the acronym for the combination of the Religious Order Study and Rush Memory and Aging Project, in one study of 1,000 decedents, they were able to identify over 230 unique combinations of neuropathologies. And they found that mixed dementia does increase with age and is quite prevalent in people who are over the age of 85. However, most of those people had been diagnosed just with a single specific dementia. So more of what we've learned from autopsy studies. Another thing that has been really fascinating to find out from these long studies where people get autopsied at the end is that neuropathology is not destiny. So in particular, they noticed that many participants had Alzheimer's pathology in their brain, but did not have mild cognitive impairment or dementia. They basically did not have significant problems with their memory or thinking. And so they found that the amount of disease, we could say, in the brain, had a correlation with symptoms, but is imperfect. And there were some people who seemed to have quite a lot of change to their brain and were still functioning okay. And there would be other people who had less change to their brain, but were having cognitive symptoms. So what this means is that, when people have neuropathology, the impact on cognition is highly variable. And this is why some experts, including many geriatricians, feel a little squeamish about the idea of everybody now getting a special scan to find very early if they have signs of Alzheimer's pathology, because we don't know who's actually going to develop symptoms and when at this time. So also what we learned from the autopsy studies is that Alzheimer's pathology is really, really common, but it's rare, especially when people are above age 80, for them to have only that. So in one ROSMAP study, and the average age of people at death was pretty far up there. It was 89.7, so essentially 90. 65 of them had Alzheimer's pathology, but only 9% had isolated Alzheimer's disease. So in short, when it comes to older adults and their brains, especially if they have developed dementia, it's mixed dementia that is the most common type of dementia, especially a mix of Alzheimer's and cerebral vascular disease. And we also know that lots of people have neuropathology changes if we look in their brains, but many of them do not develop symptoms. And when people do have dementia, it's important to realize that there can be so much variability under there, and it's going to be really difficult to detect with just clinical care, even if you go to a memory and aging center, because it could be there are so many combinations that are possible. And so this might explain why, when people have dementia, it can be so variable how their dementia manifests or progresses. It's partly because all kinds of things can be going on in the brain from a neuropathological perspective. So given all this, does identifying the type of dementia matter? And what I would say is it really depends who you ask. Certain types of experts, especially the ones who work in memory and aging centers, they're often doing research on a lot of these types of dementia. There are lots of people who feel like it matters. We should try to find out. And then there are others, maybe like myself, who think, well, it kind of depends a little bit on the circumstances of the person. So I would say that it depends on the age of the person and on their symptoms. I have been working online for a while, and I have seen so many expert resources say that, if there's dementia, you should get the type identified so you can get appropriate specific treatment, or it's really going to make a difference. But the truth is, it's very rare for us to have an effective specific treatment available for a cause of dementia. So when I read this, get an appropriate specific treatment, I think, what treatment are they talking about? Because what treatments do we have for dementia right now? So the most commonly used treatment is oral dementia medications. We've had some FDA approved for many years right now. So one class of them is called cholinesterase inhibitors. This includes medications like donepezil, rivastigmine, galantamine. The brand names for those are Aricept, Exelon, and Razanine. And then there's a different type of dementia medication called memantine. The brand name for that is Namenda. And the thing about these is that they're not really specific to any dementia type. When they were studied for FDA approval, The researchers did not have a way to try to really identify the dementia subtype. It was, dementia presumed Alzheimer's, usually either mild to moderate or moderate to severe in severity. And for what it's worth, memantine was not FDA approved for mild to moderate. It's supposed to be for moderate to severe. And all of these medications failed the phase 3 trials for making a difference in mild cognitive impairment too. But anyway, these medications are not specific to any dementia type. And they usually also only have a small effect on cognition, if any. And then just in the last few years, as of, 2021, 2022, we have some new anti-amyloid antibody Alzheimer's treatments, such as the drug Leqembi. Now, these are specific for Alzheimer's because they help the brain not create amyloid plaques. So they definitely slow the accumulation of amyloid plaques. However, it's not yet clear how clinically significant this will be. In the phase 3 trial for Leqembi, people who were on the drug still declined cognitively over 18 months, just less than people who got the placebo drug. And these drugs also have some pretty significant side effects that require monitoring. So it's true. Potentially, if you can confirm that you are dealing with Alzheimer's disease, you could be eligible to try something like Leqembi, but otherwise, most of our dementia treatment options are not really specific to a type of dementia. And also when it comes to Leqembi, we don't really know how effective it'll be when people are into their 80s and 90s, especially because those are people who probably along with their Alzheimer's have other forms of dementia going on as well. And then very briefly, I do want to acknowledge that, as I mentioned, there are, a few less common types of dementia that, could potentially be treated. So normal pressure hydrocephalus can sometimes be treated by placing the shunt to drain the cerebral spinal fluid into the abdomen. But this is not very common, often coexists with Alzheimer's pathology. Alcohol-related dementia sometimes gets better if people stop drinking, if we treat thiamine deficiency. And then chronic subdural hematoma can potentially get better either with time or with drainage. So given all this, let me share with you now what is my approach to types of dementia. So being a geriatrician and having tried to follow the research and literature on this, I know that most older adults, especially if they're age 80 or older, have mixed dementia. And I know that all the common forms of dementia, so the most common forms in older adults, Alzheimer's disease, cerebral, vascular disease, and Lewy body, can have a lot of variability in how they manifest in different people, and they can have a lot of overlap between each other, right? So, both Alzheimer's and cerebral vascular disease can cause short-term memory loss or possibly, strange beliefs. So because of this, I don't particularly try to get too much into which type of dementia it is. What I do think is important to do is to check for symptoms of Lewy body dementia. And the main reason for this is because people who are having signs of Lewy body, that can make them very sensitive to drugs that block dopamine. So the Lewy bodies are often involved in dopamine management in the brain, and people who have Lewy body can be very sensitive to anything that blocks dopamine. And that includes many antipsychotics, which are, sometimes prescribed to manage difficult Alzheimer's behaviors or sundowning or dementia behaviors. Otherwise, I focus on assisting with symptoms, supporting family, and improving the quality of life. And let me also say that, with this approach, this is presuming I have already done, an evaluation to check for dementia mimics. And I've usually also already thought about, have I checked for alcohol use? Do we need to consider normal pressure hydrocephalus, and making sure that there's been an MRI or scan to make sure we're not dealing with chronic subdural hematomas as well. So in terms of, what I think of as thinking like a geriatrician, as geriatricians, we often consider these kinds of questions when it comes to, do we want to do more for diagnosis or evaluation? And that is this going to change medical management, right? Will this make a difference in what we prescribe or don't prescribe or, other aspects of medical care? Will this enable us to better help our patients? And will this information help the patient or the family? So sometimes getting an evaluation, if somebody has worrisome signs that correspond to one of those more rare types of dementia, it's not curable, But sometimes getting that information can help people do a certain type of preparation or planning. But otherwise, it's so kind of variable the way, especially when people are in their 80s and 90s, the way their dementia might progress. And it's mixed dementia often that I find trying to figure out the types doesn't help me so much with these things. So if you are dealing with memory or thinking problems, possible dementia of some type, and you're thinking, but I think I might want to know, I think that's okay. I just want you to be informed as you consider pursuing that further. So here's what I would say are the pros and cons. So the pros of trying to find this out, in my experience, many families seem to find this really meaningful and helpful. It's not even often clear to me whether, I guess, the basis for the diagnosis, but I work a lot with families online in kind of a coaching capability. And families will tell me that they went and saw a neurologist or sometimes a memory center, and we're told it's, Lewy body for somebody in their 90s. And I kind of think to myself, well, I don't know, because the autopsy studies show that just isolated Lewy body is really rare in people like that. But families seem to often find it helpful. So I do want to acknowledge that. And it's possible that getting that additional information might help you better understand whatever symptoms you are seeing in your loved one and what to expect. Or if you are the person who has the dementia diagnosis, you might find this information helpful in some way. But there are some downsides to pursuing this. So one of them is that it often takes a lot of time and effort to get into a memory clinic for a detailed evaluation. So especially if you are dealing with somebody who is reluctant to see the doctor, doesn't like to go in, is denying they have a problem, is it worth doing all of this? And, it might not be, because again, especially once people are in their 80s and 90s, I personally find that it doesn't change management all that much. And again, in people over age 85, the answer is that what they have is likely to be mixed dementia, and there's going to be variability in that dementia trajectory, whether or not it's mixed. There is a lot of variability in people's dementia trajectories, and that's in part because, which part of the brain is affected by the pathology first, and also because many of them, if we actually get an opportunity to look under the hood and look at the brain tissue, they have multiple processes going on. And then lastly, there's no particular medicine or treatment available for the most common types of dementia that affect older adults. So if you're still thinking you want to go ahead with this, I do think it's most likely to be useful in people who are, there's a small group of people who unfortunately develop dementia symptoms in midlife or before age 65. So I think, exploring the dementia type is more likely to be useful in that group, or in what we call young old adults. So people who are age 65 to 75-ish, right? You might need to find a special memory clinic. Your average primary care provider, the average primary care provider seems to have difficulty just diagnosing dementia in the first place, never mind getting into detailed types. And neurologists, I think, vary in their comfort in doing it. And also when it's not a very detailed evaluation, the autopsy studies show that people often don't, get the type of dementia right. So you would want to look for a special memory clinic. Another option would be to consider looking for a trial. There are lots of trials related to Alzheimer's and other forms of dementia listed at alzheimers.gov. And the good thing about a trial is that as part of the trial, you can get a more in-depth evaluation, and then you might also be able to access a newer treatment. And you're both furthering the science, and it might even be helpful to you or your family member. So about better dementia care, I think in the end, what we all want is for a person who has dementia, regardless of what type of dementia, to get, the best care possible. And I know that initially what people want, and I want this for them too, I think what people want is they want a cure, right? They want something that makes the dementia stop, that ideally reverses it and makes them the way that they were before. And I really wish we had this available right now, especially for people who are in their 80s and 90s. And we mostly don't for now. So if we want better dementia care, what are our options? And these are the things that I believe make the biggest difference to the lives of people who are living with Alzheimer's or another form of dementia. So one is for them and their family, especially their family and care circle, to learn better dementia communication strategies. It's to learn to focus on what can be done to help the person make the best of their remaining abilities, or maybe tap into some other abilities that they haven't used so much before. So for instance, a lot of people with early Alzheimer's find that they're still able to be very creative and engage in art and in music. And these might be things that they never took time to do before, but that might be accessible to them. There can be ways to help people still leverage the abilities that they still have to work around whatever limitations that they are developing. And there are usually lots of ways that we can try to help optimize the quality of their life so that they can have the best possible life, given the circumstances now and for the future. I think it's also really useful to learn strategies to manage any challenging behaviors or difficulties that are coming up in your situation, whether that's, false accusations, being unaware of their difficulties. There are strategies out there. They do, require some coaching, some practicing. They require patience, a lot of patience. There's no magic pill, but those can be taught. And when families learn that can, really reduce the stress in the household, and I think makes an important quality of life difference, both for the person with dementia and for their family. Support groups. I can't say enough about the importance of finding support groups. There are support groups for people who have dementia where you can connect with other people going through this experience. There are support groups for people whose spouse has dementia or whose parents have dementia. And it's just so, so valuable to be able to process the feelings with people who understand and also learn some practical information or strategies from others who are in this. So I just really recommend looking to talk to experts and fellow travelers to learn more about not just what's going on now, but what to expect. And if you have the bandwidth to do so, to plan appropriately when you can, because that does make things easier down the line when the situation has evolved and progressed and, care needs to change, or maybe the goals of, medical care need to be revised. And then there's practicing self-care and acceptance. Again, important for the person with dementia and important for their family and their care circle. So this is what I believe makes the biggest difference. And for all of this, you don't really need to know the type of dementia. What you do need to do is tap into a place to learn this and to get this type of support. So I do run online programs helping older parents, and we have one that's for helping parents with memory loss. And then you can also look around and find other programs either online or locally is often great. Just call your local Alzheimer's Association chapter. They should be a really good resource, so you can look on Family Caregiver Alliance's website online as well. So to recap about types of dementia. So in short, in older adults, it's mixed dementia that is the most common type of dementia. So if you are, are in your 90s or caring for somebody in your 90s and you're told it's this specific type of dementia, I just want you to remember that statistically, that's not super likely to be that dementia and nothing but. It's usually mixed dementia, especially Alzheimer's disease and cerebral vascular disease. I do think it's useful to check for Lewy body dementia symptoms, especially hallucinations, REM sleep behavior disorder, cognitive fluctuations or signs of Parkinsonism, slowing, resting tremor, gait instability, stiffness. And that's because if people have signs of Lewy body dementia, this can affect medication sensitivities, especially if you're considering using antipsychotics for behavior management. And then unless there are unusual symptoms, I find that an extensive evaluation to identify the type often doesn't change management all that much. So if you really want to pursue that, go ahead. I just want to make sure you have, good information as you go into that. And then last but not least, the most important forms of dementia care when it comes to quality of life and well-being are non-medical. So always remember that. And these, for the most part, are not going to depend much on the type of dementia. And for these, it's really a matter of figuring out how to get support in learning those aspects of care and in finding, resources that can help you provide that. And I hope you'll be able to do that. That said, I do think it's important to be educated about dementia and different types. And so I hope this episode explaining types of dementia will be useful to you. And with that, thank you so much for watching or listening. If you found this video podcast helpful, if you're here on YouTube, please go ahead and subscribe. It really helps more people find the channel. And if you have been listening to the audio version of the podcast feed, please come take a look at the video if you get a chance. You can see my key points being displayed on the screen. So thank you once again for being here, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.